The test your ER doc ran for MCAS, by the time they drew your blood, it was probably already useless, and that's not your doctor being careless. It's a timing window most physicians have never been taught exists. Hi, my name is Dr. Kara Wada. I am a quadruple board certified allergy, immunology, lifestyle medicine doc. I also live with an autoimmune condition myself. So when I say I know what it means to feel dismissed by the system you're supposed to trust, I mean that. Today I'm walking you through the 7 warning signs of a mast cell activation syndrome. We're going to talk about those high risk warning signs. Before we dive into that, I want to get to something a little more important first, which is the testing problem. There's a specific window of time when your blood needs to be drawn, or the results will inevitably, almost always, come back normal. And here's something people will miss entirely, which is urine mast cell testing. Blood isn't the only way to catch biologic evidence of mast cell issues. Certain metabolites like N-methylhistamine, prostaglandin D2, and leukotriene E4 can show up in urine and be measured in now a single void specimen. Previously, we had to have you collect your urine for 24 hours, keep it in the fridge. It was kind of a big pain in the butt. But this will give your doctor a snapshot of mast cell activity that blood alone can often mix. So that's what we're fixing today. I want you to save this video before you go to another appointment. The information here is what you can use to bring more educated questions to your personal healthcare team. And a quick disclaimer, these are the major warning signs. This is not a comprehensive list. MCAS is a shapeshifter and it can affect nearly every organ system. And what we know and how we conceptualize it is still evolving. Let's dive into the testing problem. The primary biomarker that we are taught as allergist immunologists for MCAS is tryptase. But your tryptase will often come back normal if you're getting it outside of a 30 to 4 hour window after your symptoms start. That is the ideal time when you want to draw tryptase. After that, before that, it returns to a baseline. And for most folks, that baseline is going to be normal unless you have one of 2 different diagnoses. Something called hereditary alpha tryptosemia affects about 6% of the population, where folks just have extra copies of the tryptase gene, so their level is at baseline higher, or something called mastocytosis, which is a little more rare and also needs to be identified so that that can be addressed adequately. It is really also important to have a tryptase during that critical window of 30 minutes to 4 hours after a flare-up in symptoms, but you want to compare that to a baseline when you are symptom-free. Both numbers are used then to run a diagnostic calculation that are part of the Consensus 1 diagnostic criteria. Often, that timing for a blood draw is really challenging. And so that is where I lean in on some urinary studies that are run by Mayo Clinic. That includes the N-methylhistamine, the prostaglandin, and the leukotriene metabolites. This can be helpful to capture kind of the smoke rather than, direct evidence of the fire when it's been burning for a while. Something really critical, super important, is that urine needs to be cold and chilled immediately after you pee in the cup. And so I tell all of my patients to bring a bag of ice or an ice pack with them so they can set that little cup on the ice and buy yourself a little extra insurance policy, because that lab tech, he or she, they are doing their best, but often they're busy. And so it may not be put in the fridge or on ice as quickly as we need to really try to get accurate data. So if you bring your own bag of ice, that can help provide a bit of an insurance policy. All right, now let's jump into these 7 signs. We're going to fly through these because I know you're busy and we want to cover the highlights. So sign 1 is dermatographism and itching. Dermatographism is when your skin develops red raised lines or wheals. That's the raised part after scratching or pressure. Essentially, you can write on your skin. And this happens because your mast cells are hyperreactive to physical touch or the disruption on their cell membranes. This on its own is not a huge red flag, but when it occurs alongside some of these other systemic issues, that's when the alarm bells start ringing. Sign number 2 is sudden unexplained flushing. Sudden flushing, this intense heat, redness on your face, your neck, your chest, it is kind of miserable. And it's unlike a normal blush. It can be episodic and persistent in MCAS. Triggers often include heat, stress, Alcohol is a huge trigger. Sometimes the use of non-steroidals. It can look and feel like a panic attack, and so it can often be misdiagnosed as anxiety. And it can overlap and feel and look very similar to hot flashes we can experience during perimenopause and the menopausal transition. So again, this is where the whole context is really important. Sign number 3, unpredictable gastrointestinal issues. Feels like IBS, probably has been diagnosed as IBS. The triggers will often shift. One food that was fine yesterday can cause explosive diarrhea or cramping today. And this happens in part because the GI tract is packed with mast cells. They are found right alongside our small fiber nerves, and those two structures are together trying to ensure that our body is staying safe. When there are issues that disrupt the barrier of our GI tract, we have changes in our microbiome, then our mast cells and our small fiber nerves, which are responsible for the motility, can get overwhelmed. I see this a lot, especially in my patients who also have autoimmunity like Sjogren's, because of some shared amplifying inflammatory pathways that really can egg on mast cell reactivity, stuff like interleukin 33. Sign 4 is a racing heart and dizziness. Cardiovascular instability. Your heart races, you feel dizzy, just standing up. When mast cells release histamine and some of those other mediators, your blood vessels dilate, causes your blood to pool in your legs, and that's why MCAS and things like POTS, or postural orthostatic tachycardia syndrome, are so often found in the same individuals. Sign number 5, okay, we're getting more severe as we go here. Wheezing and shortness of breath. Respiratory flares, sudden wheezing, chest tightness. Rescue inhaler may or may not fully fix it. Mast cells release leukotrienes, which are more potent than even other chemicals at constricting our airway. If your asthma feels weird, if you're being triggered by strong smells, and you're having these other systemic issues and symptoms, then we need to be thinking beyond maybe the typical asthma and or vocal cord dysfunction. Sign 6 is facial or throat swelling. The medical term for this is angioedema, sudden swelling of the lips, eyelids, tongue, throat. If your throat or tongue swells, this is a 911 emergency. If you carry an epinephrine auto-injector or inhaler, this is the time to use it. Epinephrine works fast. It hits the root cause. This is not a time to mess around with antihistamines, which do not reverse this process at the core. This is where epinephrine is needed. All right. We're getting to number 7, which is the MCAS signature, which are multi-system episodes. In MCAS, you don't just get one symptom in one system. You get a cluster. That's what kind of makes MCAS more than asthma, more than chronic hives, more than just one thing. It's flushing plus a racing heart plus stomach cramps all at once. This is the definition of systemic activation. And this is why part of the diagnostic criteria, symptoms must affect at least 2 different body systems in the same period of time. Now, I take care of a lot of patients who have Sjogren's, which is an autoimmune condition that often affects these small fiber nerves. And what I was realizing and noticing with these patients as I was seeing more and more of them, we were also seeing these signs and symptoms of mast cell activation. And there is some science behind this, although not much science has actually looked at these 2 conditions together. We're working on that at the Immune Confident Institute. But some of the underlying driving factors like type 1 interferons are the same factors that are increased in Sjogren's. They also prime your mast cells to be more trigger happy. So these 2 conditions often seemed clinically in my practice and in my patients to seem to feed off one another. It's really important to have a treatment plan that addresses both, or we end up just chasing our tails and those symptoms. So I'm going to leave you with 2 things to do today. Number 1, start an episode log. Record the date, the time, triggers, your systems that are affected. I would think about potential triggers up to 24 to 36 hours before you had a flare up. I also would really encourage you to think more broadly. We often tend to associate, in particular, food or lotions and potions and things. Those tend to have this natural connection to something activating our system. But I want you to think a little more broadly. How was your sleep? How was your hydration? How was your stress level? All of these things are contributory potentially to a flare-up. I also want you to ask for questions. When you're seeing your primary care doc or your allergist, you can ask them, hey, I understand tryptase can be time dependent. Do you have any best practices as to how we could get this drawn in that critical window of time? They may or may not have this, and don't fault them if they don't. It can be really challenging. Even I work in a very medically resourced area, and I still have trouble sometimes coming up with a plan to get that tryptase drawn when we actually need it. You can also ask them if they'll order a baseline and if they are willing to order those Mayo Clinic urine tests that are also very helpful. I think it's also a really valid question to ask, will you consider still treating me if my labs are normal, especially if I am improving with mast cell directed therapy? This is an area that is unfortunately more contentious than it should be. And it's really important to find someone that is a good fit and that's going to work with you and that you have a good therapeutic relationship with. Normal labs do not fully rule out MCAS. Diagnosis is often clinical, and we are looking to try to find supportive lab data as we go, in part because a lot of these labs are finicky. What I base my clinical practice on is, what is your pattern? What is your response to treatment? What are your labs? The reality is, I know that you're not exaggerating and what is happening is real. I want you to save this video before your next appointment. If you know someone who's been told their labs or their tests are normal, but their body's saying otherwise, send this to them. This is exactly who this is for. Now, there are two ways to go deeper from here. There's a quiz in the description called the Immune Confident Indicator. It takes about 4 minutes. It's going to show you your baseline kind of inflammatory burden across your immune system, across metabolism, cardiovascular health. It's free and the link is below. If you want a more detailed picture, we also offer something called the Immune Confident Blueprint Checkup. It's a little bit like Function Health, but from the mindset of an allergist immunologist. It's not a doctor's visit. It is an educational roadmap that takes into account where you are and you can use with your existing care team. Details are in the description as well. Now, for those of you who are already patients with our clinic, the Immune Confident Institute, don't go buy the blueprint checkup. We've got you. Just message Terrain in your portal instead, and we'll handle the labs as part of your care plan. Until next week, I hope you stay well and take care.